I'll be discussing about the calcium on following headings: about the introduction, the calcium metabolism, and role of calcium metabolism in the hormones of parathyroid hormone, calcitonin, and vitamin D, the functions of the calcium and the disorders of the calcium. With the introduction, the calcium, the total body content of calcium is 1,300 grams. Of this, the bone contains about 99% of calcium. In the intracellular, 1% of calcium is present, and the extracellular 0.1% calcium. The total plasma calcium is about 2.5 millimoles per liter, and the normal serum calcium level is 9 to 11 milligram per deciliter. The calcium is broadly divided into the protein bound and the ultrafiltratable. The protein bound is 40% and the ultrafiltratable is 60%. And ultrafiltratable, it's further divided into complex ions and the ionized calcium. Ionized calcium, it accounts about 50%. The most common and which is very important in the disorders of the calcium metabolism is the ionized calcium, and I will be discussing about this in the next future slides. Coming to the factors affecting the calcium concentration, the changes in the plasma protein concentration with the increased protein leading to the increased total calcium levels, and changes in the anion concentration, increased anion leading to increased fraction of the calcium, that is a complex, and leading to the decreased ionized calcium levels. And acid base abnormalities, they affect the calcium metabolism. And the main function of role of calcium in the action in the cardiac myocytes are the increase in the intracellular calcium concentration. The calcium binds to the troponin, and there is a conformational change in the troponin complex. They move the tropomyosin out of the way, leading to the binding of the actin to the myosin heads. They form a cross bridge formation, and the muscle contracts as a whole. The cardiac action potential and its applied clinical pharmacology are based on which the normal resting membrane potential is minus 90 millivolts, and phase 1 where the sodium influx occurs via the fast channels, and potassium efflux returns to the transmembrane potential, and phase 2, which includes the calcium influx via the L-type calcium channels to the balance with the potassium efflux from delayed rectified channels, and phase 3, which includes the calcium channels close and potassium efflux continues, returning the transmembrane potential resting minus 90 millivolts, and based on which the class of antiarrhythmic drugs were been identified. The class 1, the sodium channel blockers, which includes the quinidine and procainamide, and lidocaine and phenytoin, flecainide and propofenone, and class 2, which includes the beta blockers, the propranolol and metoprolol. Class 3, which contains the potassium channel blockers, amiodarone, sotalol, ibutylide, like that. And class 4, which includes the potassium channel blockers, verapamil and diltiazem. And functions of calcium, which also includes, it plays a major role in the homeostasis and activation of the clotting enzymes. The calcium, which is also called as a factor 4, which plays the important role in the coagulation cascade in the extrinsic pathway, and also it plays a main role in the intrinsic pathway, where it mainly it acts along the factor 9. Along with that, it enters into the common pathway, thereby it forms a stable fibrin clot. And the next functions of calcium includes the preserving the bone density and maintenance of the bone and teeth. It helps to reduce the occurrence of the osteoporosis, and it also plays a major role in the neurotransmitter release of the neuromuscular junction, where it has the arrival of the action potential to the axon terminal and opening of the voltage gated sodium calcium channels, and the calcium influx into the terminal, the transmitter release with exocytosis and release of the transmitters into the clefts. And calcium is also assists in maintaining the cells and connective tissues in the body, regulating the mitotic transition and the cell divisions, the essential components in the production of the enzymes and hormones. They also regulate the digestion, energy, and fat metabolism. The calcium homeostasis, it's mainly the principal organ systems are the intestine, bone, and the kidney. The major hormones which play the calcium homeostasis are the parathyroid hormone, vitamin D, and calcitonin. Here you can see the major role of calcium homeostasis in the intestine, kidney, and the bone. Coming to the parathyroid hormone role in the calcium homeostasis, they increase the parathyroid hormone, increase the extracellular calcium, and calcium binds to the receptors and which activates the phospholipase C and increase the levels of IP3 and calcium. They inhibit the parathyroid hormone secretions. When the extracellular calcium is decreased, which stimulate the parathyroid hormone secretion. And parathyroid hormone, it also inhibits the phosphate reabsorption. It inhibits the sodium phosphate co-transport in the proximal convoluted tubule, leading to phosphaturia, less complex calcium phosphates, and they stimulate the calcium reabsorption on the distal convoluted tubule. Coming to the role of parathyroid hormone in the small intestine, they stimulate the calcium reabsorption via activation of the vitamin D. They stimulate the renal 1-alpha hydroxylase, converting the 25-hydroxycholecalciferol to 1,25 dihydroxycholecalciferol, which is the active form of vitamin D, stimulating the intestinal calcium absorption. Here, the parathyroid hormone playing the major role in the bone, kidney, and the intestine. In the kidney, there will be a reduced phosphate reabsorption and increased calcium reabsorption, leading to the increase in the urinary cyclic AMP and the increased plasma calcium levels towards the normal levels. Role of calcitonin. The calcitonin is a peptide containing 32 amino acids. They are secreted by the parafollicular cells of thyroid glands. Calcitonin is the antagonist action of the parathyroid hormone. The direct inhibition of the osteoclast. They promote the calcification by increasing the activity of osteoblasts, decreases the bone resorption, and increases the excretion of the calcium into the urine. The action of vitamin D. Vitamin D in the bone, it promotes the bone resorption and increases the calcium and increases the phosphate. In the kidney, they increase the calcium reabsorption and phosphate reabsorption. In the intestine, they also increase the calcium and phosphate absorption and synthesis of the cal-binding to 2K. Role of calcium in the handling in the nephrons. The 67% of the filtered load is reabsorbed at the proximal convoluted tubule. Calcium reabsorption is tightly coupled to the sodium reabsorption in the proximal tubule. Here, the loop diuretics such as the furosemide, they inhibit the calcium reabsorption to the same extent, and they inhibit the sodium reabsorption. Whereas the thiazide diuretics, they increase the calcium reabsorption, while the other classes, they decrease it. To summarize, the role of calcium, calcium has many essential biological functions in excitation coupling in the myocardial, smooth muscles, and the skeletal muscles, in coagulation of the blood, and transmission of the synapses, and they play a major role in the hormone secretions and major intracellular messenger for maintaining the normal cellular function. For we as anesthetists, we have major effects of calcium in the myocardium, vascular smooth muscles, and blood coagulation. Coming to the disorders of the calcium, the hypocalcemia, it is defined as the plasma calcium concentration of less than 2.1 millimoles or the ionized calcium level is less than 1.1 millimoles per liter. The most frequent cause is hypoalbuminemia and hyperventilation, or by excessive citrated red blood cell transfusion. The signs and symptoms of hypocalcemia, which includes mental status changes, tetanus, and positive chostic sign, which is the contraction of the facial muscles produced by tapping on the ipsilateral facial nerve, and Troussier sign, which is the carpopedal spasm with the contraction of the fingers and an inability to open the hand, elicited by inflating arterial pressure cuff to slightly above the systolic arterial BP. Here, the Troussier sign, the blood pressure cuff is inflated to 20 millimeters of above the systolic blood pressure, and you are able to see the carpopedal spasm at the flexion at the wrist and flexion at the metacarpophalangeal joints and extension of the interphalangeal joints. This is the Chostek sign. The patient is asked to relax his facial nerves, and we have to stand in front of him and tap the facial nerves, either just anterior to the earlobe or below the zygomatic arch. And we are able to elicit the facial muscle twitching and contractions. ECG changes of hypocalcemia, which includes the prolongation of the QT interval and AV conduction blocks, and other clinical features including the laryngospasm, hypotension, and cardiac arrhythmias. And treatment of hypocalcemia that includes the calcium salt solutions. The available intravenous calcium solutions are 10% calcium chloride and 10% calcium gluconate. Calcium gluconate is most commonly preferred because it has the lower osmolality and less irritating when injected. The elemental calcium in the calcium chloride is 27 milligrams. In the calcium gluconate, it's 9 milligrams. The osmolarity is in the calcium chloride is 2000 milliosmoles per liter, and in the calcium gluconate, it's 680 milliosmoles per liter. Coming to the dosing regimen of the hypocalcemia treatment is the bolus dose of 100 milligrams of elemental calcium. It's diluted in the 100 ml of isotonic saline and given over for 5 to 10 minutes. The bolus dose, it has to be followed by the continuous infusion at the dose rate of 1 to 2 milligrams per kg per hour. The calcium dosing, it has to be guided by the level of ionized levels of calcium in the blood. And maintenance oral calcium therapy that includes the 2 to 4 grams in the adult. Oral calcium carbonate or the calcium gluconate tablets available 500 milligrams of calcium per tablet. And management of anesthesia in the hypocalcemia, it's symptomatic hypocalcemia. It has to be treated prior to the surgery. Intraoperatively, it occurs with hyperventilation or administration of the bicarbonates. Ionized calcium levels can be decreased during the massive blood transfusion of blood containing citrate. And sudden decrease in the serum calcium may be seen in the early postoperative period after thyroidectomy or parathyroidectomy, and it may also cause laryngospasm. Coming to the hypercalcemia, and we are all aware about the famous quote for hypercalcemia of painful bones, renal stones, abdominal groans, and the psychic moans. The increased calcium reabsorption, it's from the gastrointestinal tract, which includes like conditions like milk alkali syndrome and vitamin D intoxication, granulomatous diseases such as sarcoidosis, and decreased renal excretion in the renal insufficiency, and primary or secondary hyperparathyroidism and malignancies conditions. And clinical manifestations of hypercalcemia, the neurological conditions, they include the confusion, depressed consciousness, including coma. In cardiovascular conditions, they include hypotension, hypovolemia, and shortened QT interval. In gastrointestinal, it includes nausea, vomiting, constipation, and pancreatitis. And renal conditions, they include polyuria and polydipsia and nephrocalcinosis. And Here the ECG changes of hypercalcemia, which includes the shortened QT interval. The manifestations of hypercalcemia, they become evident when the total serum calcium it's more than 12 milligram per deciliter, or the ionized calcium is more than 3 millimoles per liter, and are almost always present when the serum calcium is more than 14 milligram per deciliter. Coming to the treatment of hypercalcemia, which includes the isotonic saline infusion. The hypercalcemia is usually accompanied by the hypercalciuria with osmotic diuresis. The isotonic saline is infused at 200 to 500 ml per hour because of the natriuresis promoting the renal calcium excretion. The goal of urine output in hypercalcemia treatment is about 100 to 150 ml per hour. And furosemide, which is included in the saline infusion, to further promote the excretion of the urinary calcium, furosemide is added at the dose of 40 to 80 milligrams IV every 2 hours. And glucocorticoids are also used in the treatment for the hypercalcemia, where we use prednisolone or hydrocortisone. The dose of prednisolone is 40 to 100 milligrams daily, or the intravenous hydrocortisone 200 to 400 milligrams daily for 3 to 5 days. And bisphosphonates like zoledronate or pamidronate are used. The zoledronate, the dosage is 4 or 8 milligrams IV over 15 minutes, and pamidronate, it's 90 milligrams IV over 2 hours. The bisphosphonates have a delayed onset of action. The peak effect is 4 to 7 days, and the effect lasts for around 1 to 4 weeks. The management of anesthesia in hypercalcemia, ideally the surgery has to be postponed until the serum calcium levels has to be normalized. In case of emergency surgeries for a hypercalcemia, we have to restore the intravascular volume prior to the induction and increasing the urinary excretion of calcium with loop diuretics. And thiazide has to be avoided as they increase the renal tubular reabsorption of the calcium. And central venous pressure or the pulmonary artery pressure monitoring has to be advised for recurring for the fluid resuscitation, and dosing of the muscle relaxants must be guided by the neuromuscular monitoring. And thank you, sir.
Thank you. You are a first year postgraduate, is it?
Yes, sir. I'm first year postgraduate, sir.
Very good. Excellent. Congratulations for taking so much pains to prepare the PPT and making a good presentation.
Thank you, sir.
You could have added, of course, because you already prepared all this and then presenting it. I told about the importance of calcium in liver transplant surgery, because calcium and potassium are the two culprits which can cause problem. So maintenance of calcium level is very important in liver transplant also. And I think I have you can start writing. If supposing such a question is asked in the examination, first you start about the homeostasis of calcium, how calcium levels are maintained in the blood by the action of three systems, namely the gut is from where the calcium is absorbed, and then kidney from where it is eliminated. In between, how the parathermone of the parathyroid gland helps in maintaining the levels, and how calcitonin antagonizes this. So that is why it is very easy to understand. So absorption, what is the total quantity of calcium absorbed? Majority are excreted into the intestine and eliminated by feces also, apart from the kidney. So hardly 100 milligrams are retained from what it is absorbed. We almost take 1000 milligrams every day, but almost 800 to 900 is lost again in the feces. Only 100 is taken. And one more thing missing in your presentation is the calculation of corrected calcium. how to calculate the calcium in your. You can close your screen, Praveen.
Yes, sir. Okay, sir.